Yeah. We're live.
Why don't we all tweet it out right now?
All right. I will tweet out the link.
This is cool technology, though, huh? How like keep switching between us when we talk.
Where's the link, Erson? Is it on whose site?
It's on manualtherapist.com. You can watch it live on there. I put it on my site. Okay, I'm going to shrink this. I'll mention you guys. You want Mike Reinold or at Mike Reinold blog?
I'm just at Mike Reinold.
Okay.
Cool technology, though. I have like keep switching. Oh boy.
Where's the link, Erson? Is it on whose site?
It's on manualtherapist.com. You can watch it live on there. I put it on my site.
This is like Groundhog's Day right now. What's going on?
What is going on? Why is it like
conversation just happened?
Mention you guys. Is there not that much of a delay?
What is happening right now?
This is the best college show ever.
Where's the link, Erson? Is it on?
Yeah, we have 2 viewers.
Good thing no one's watching us. Good thing nobody knows how to watch us.
Well, this is right. There's 5 viewers now. That means people are actually watching.
Those are all people that are following me.
Dude, I don't know if I can handle this.
I'm opening up the Q&A so people can actually ask us questions. Oh, give me a break. Come on, I can't open this up now. Yeah. For the broadcast.
No one's watching us. I think nobody knows how to watch us.
Five people are actually watching.
We need to work on Erson's style a little bit, Mike.
Are we okay? I feel like we just went through an earthquake or something. That was crazy.
Anyone have any questions? People are like popping in and out. Yeah, this sucks.
Well, Erson, I'll let you handle it. I'm going to just eat dinner. Let me know what's up.
My first question is, Mike, what are you eating tonight?
I am eating a very non-paleo diet. This is probably the first time I've had macaroni in years.
Wow.
I'm not sure why. I don't control my dinner menu. I just consume. But I got about a pound of grass-fed beef on top, so that helps.
Grass-fed beef is the best. Yes.
Good.
Chris, what do you eat? Anything?
Predominantly. Yeah. I actually, what was funny is that this woman actually told me that I had nice legs today, and I didn't know if, how to really look into that. It was sort of strange. I'm like, does that mean that like they're not that strong or something, or like, it was very confusing, and it hit me first thing in the morning. So I took it as a compliment. But I eat predominantly beer and. Actually a lot of carbohydrates. My wife got us going pescatarian, I think is a technical term. She said, beer, we're going to stop eating meat. And I said, okay. And actually someone was asking me if it was a tough transition. Actually, not at all. But out here, the food's so good in Seattle. I mean, especially the seafood. So.
Okay, so you eat seafood.
Yeah.
No, I was going to say, let's all go crazy here.
Yeah, no, not too crazy.
Dude, grass-fed beef is awesome. I don't know how you could not eat it. with me. I give it hard to do. Get so many stories. I don't know.
Dude, I think you're covering your mic on your laptop or something.
I don't know.
That's better.
Is that better?
Yeah, that's way better.
Okay, all right. It was one of my hands. I don't know where my mic is, apparently.
You made me laugh.
What in the hell is going on?
Luckily, it's just the three of us.
No way. Well, you know, there are actually people who are watching. If you guys are actually hanging in there, thank you. I don't know. Let me see if anyone is on my Facebook page and asked us a question.
How do they ask us questions? I'm thoroughly confused.
They were supposed to be able to, like, kind of like call in with the, you know, and when they're viewing this, they should be able to interact with us at the same time. Sorry, guys. I've never done the live show before. All right. Actually, I have a question from Chris Rufino. Could you suggest a valuable continuing education course or useful certification for new grads? Question I get asked a bajillion times, but you know what? That is a great question. All right. How about we let Chris go first?
Hey, can you repeat the question? Sorry.
Yes. What's a valuable Con Ed course for new grads?
Oh.
Did you want me to answer that?
Go. Do it.
I mean, I think
Back and echo. Do it.
there are so many courses out there. You know, I think that Butler's neuromobilization course is great. You know, I think even your course, Erson, you know, because it's eclectic in nature. I'm not just sitting here, but I think it gives you a little bit of a balanced approach. You know,
I was going to recommend my course.
Yeah.
Now I have to think of a different answer.
But you know, I think there's a lot of different courses. You know, something that Mike said that really stuck with me or resonated with me is I feel like a lot of younger clinicians have lost the ability to treat a joint, or they haven't really developed the ability to treat a joint. And they're taking a lot of these esoteric courses, which are great, but I think that, you know, from a priority standpoint, those should be pushed back a little bit. And I see a lot of things, especially at the level of the shoulder, that scare the living daylights out of me, and I think some of these patients are better off not getting treated. But so I think, you know, pick a region of the body that, you know, interests you, and take a course with people who are publishing on this, who are very current. You know, so I think that. What are you doing? You're fooling with putting clown faces on Mike in the background. So, but anyways, yeah, I think that there's a number of courses out there, and it takes time. Don't expect to just all of a sudden, you know, master physical therapy in 2 to 3, 5 years. I mean, it takes a long time of hands-on experience, not to rush it.
I agree. That's amazing. They even make my beard go up and down when I talk.
Echoing so much.
Yeah, who's doing that? Is that
Oh, that's me. I'm enjoying it.
Oh, okay, I gotcha.
I don't know how I did it. I just started playing with the little effects thing on the side. You should check that out. I think I can make me at the beach. Yeah, I'm at the beach.
Man,
I'm sorry. As you can tell, I'm easily distracted.
You wouldn't have that beard if you were living in that environment.
I don't know how to turn this off.
Okay, go with it.
There we go. Got it. Okay, good. Well, for me to answer that question, I would just say, you know, the eclectic approach by MedBridge. Heck, you know, I mean, I think Chris said it well. I mean, it really depends on what you want, you know. So if you want to, where do you feel your weaknesses are? If you feel your weaknesses are joint specific, then do something joint. If you feel like your weaknesses are, you know, neurological, or, you know, do that, whatever. I mean, I think as you kind of move along the spectrum of your education and what you want to learn, you'll find paths. I think if I had to recommend what's a new grad going to do from the beginning, what do I think you're not good at from school is, I would probably say some of the movement-based kind of things I think would probably be a good start, like maybe even like something like the SFMA or something like that from just kind of a broad spectrum. But realize a class like that and a continuing education class like that is just going to that is honestly, it's just going to open up a can of worms, and it's just going to make you want to learn so much more. So you're going to learn how to assess the body, but again, if you don't know how to treat a joint, you're not going to really get too far. So that would be my answer to all those people that aren't watching right now.
Hey, we got 9 viewers now. This is like
I don't even know what this means.
reviewing your times.
What was the first continuing education course?
Oh, wow. That was a long time ago. I have no idea.
Yeah, I'm trying to think myself. I think I took a course from the Institute of Physical Art on rib mobilizations in the thoracic spine, and it was just, I think, way over my head. And we were at a point where there was much greater specificity with a lot of the manual techniques, and I think the research is not so great on that topic anymore. He's totally screwing with me. I mean, this is like a bad dream.
I'm actually right beside Chris. His head is that big.
You guys are right next to each other.
I muted my mic. We're still getting feedback. I didn't want any.
I'm just enjoying these effects.
Yes. It's funny that somebody asked this. This is my top 5 Fridays post for tomorrow. But that was a great point, Mike, about whatever your weakness is. I just think that something like MDT or SFMA, something that's easy, simple. It's going to help you classify a patient. I think too much emphasis is placed on unnecessary special tests, and students don't necessarily know where to go. One of the local schools around me, they used to teach 20 special tests for the knee, and just 20 special tests, and then they kind of it doesn't really dictate your treatment. But at least something like the SFMA or MDT and locally helps you get rapid responses, helps you classify patients. When you classify patients, typically you get dictate your treatment, and that should theoretically enhance your outcomes. Yeah. That's
Back from us being in the same just in close proximity.
I feel like I should fly there.
Yeah, I know. But when are you going to shave your head? I thought you were going to shave your head if we won.
Oh yeah, I forgot about that.
Yeah. Oh, this isn't much better. Now there's just music. Can you guys still hear me?
Where are you?
I'm just outside the conference center, outside of the room, but I mean, it's like all swanky music out here.
That actually sounds pretty good.
I sound better?
Yeah.
All right. But I don't look better.
What else we got? We got any more questions?
Well, I got a question for you, Mike. So just, I always talk about patterns because I learned a long time ago that I can't teach people how to be me. We have our own, we all have our own algorithms in our head. You see neck patients, you see shoulder patients, and you think, well, what are some of the things we're going to look for, right? So, you see a typical kind of shoulder impingement, or just even someone comes to you, hey, I have shoulder pain. What are your patterns for? What are your go-to things?
I guess it all starts on who you are, right? I mean, if you're a baseball player, my patterns are completely different. If you're a CrossFitter, who I see a lot of, I think your patterns are a lot different. If you're just a kind of a sedentary, kind of normal person or whatever, I think it's different. So are you thinking more like the normal folk, like the orthopedic population?
Well, I mean, you could do 3 quick examples: CrossFitter, pitcher, and the average Joe.
I mean, so for baseball, I mean, what you start kind of figuring out, where's their symptoms while they're throwing it, like what position of the throw. Is it kind of layback? Is it coming through? What part is it? Because that's going to tell you a lot about the structure and the mechanism behind it, and then the location of the symptom. So is it, the front, the side, the back? Again, it's all different structures and different things that you could potentially be having. So For me, with an overhead athlete, my patterns are going to go based on when they feel it in their pitching motion, and then where they feel it in their body, and then that kind of starts clicking the algorithm of what it could be. So you don't, for example, if there's somebody that has some anterior instability, they're going to probably feel it more in layback. If there's somebody with a slap, they're going to feel it more in layback. If it's somebody with, cuff tendonitis or something, maybe sometimes that's kind of at release, that type of thing. Maybe it's in the front and that's at release. So that kind of, starts your algorithm. So that's where you just got to have your specific people in mind. With the CrossFitters, it's just, everything, we say CrossFit, but really, I guess anybody that's a heavy fitness enthusiast, but it's just all pull, 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 right? Everything's up off the floor. So it's, deadlift, clean, jerk, snatch, deadlift. I mean, everything's pull, pull, pull up off the floor. So they're so upper trap dominant that, for them, they almost all have like thoracic mobility, and they have restricted overhead ability here. So, your algorithms, to me, with the CrossFit folks, not going to be strength-based. It's going to be mobility-based, where they're mobility-based, because we know they're all pretty strong. And then the average kind of person, then we just have to figure out, this is the person where it's usually a combination of mobility and then core strength. So, I think we had a good kind of 3 kind of groups of subsets right there of where your patterns go. Is, it depends on what what they do all day. So I don't know if I answered that well, but that's kind of, I guess that's how I would start. At least figuring out is, how do I tackle this person individually? I think that's what you need to do first. I'm sure with Chris, like with your runners and stuff, very similar thing, right? You have somebody with knee pain that's a runner versus somebody that's a knee pain that's a basketball player. I think it's going to be a little different, right?
Yeah, absolutely. I mean, I think you just need to know the athlete, like you said, that's in your hands, and really trace it back to, with running. Is this something that is poor shock attenuation? There's such a broad spectrum with athletes. Most of the people that I'm seeing are recreational runners. With recreational runners, you're going to predominantly see patellofemoral pain and issues distal to the knee. It's not like you see Usain Bolt running and all of a sudden pull up lane with leg pain. He's going to, if anything, pull up lane with a hamstring strain. So the force starts to, or the power generation starts to shift proximally with runners. Most of the folks that I'm seeing, though, are recreational runners, and a lot of that is largely driven by poor postural stability and single leg balance. And then they start, it's just a matter of either volume, intensity, or just poor habits that land them in my hands. So yeah.
I mean, that makes sense. So you think that postural, like you said, that single leg postural thing, is an important factor with the runners. Why do you think that is? Do you think they're just so sagittal plane focused, or do you think they're, why do you think they have that?
I think a lot of times, there's a great book called Effortless Power, and it's written by this guy, Peter Ralston. He was the first Caucasian to win the world mixed martial arts. And, he has a quote along the lines of saying most people, assume that they're balanced simply because they don't fall over. With running, you have to really look at running as post-injury running and then performance running. And all you need to do is look at some of this woman, Priska Jeptu, who won the last New York City Marathon. I mean, she breaks all of the rules from a biomechanical standpoint. But you can't say it's dysfunctional because she won the New York City Marathon. When I'm working with people in a post-injury standpoint, I'm looking at things very systematically. And I tell, students or other clinicians who hang out with me, running injury management is very boring. It's a very systematic approach to getting someone back. It's, okay, do they have adequate motion? Are they able to balance on each leg in a wobble-free manner? Are they able to tolerate an eccentric closed chain, like a step down? Do they have good frontal plane stability? Are they able to tolerate a walking program? And I think this sort of gets back to what we started talking about briefly, is having a system in place. And that's something that will continue to get refined the more experience you have, the more you stay on top of the literature. And I think that's what makes you who you are, as well as Erson. You have a system in place that continues to get more refined as you go. So.
Right. I mean, we all have our systems, and that's the whole kind of point of this, and maybe we're influenced by certain kind of courses and certain kind of commercial models. But, the thing with experience, I always, for new grads, I say you need a system because you don't have one. And your school most likely did not teach you a system, and if it did, it was probably not efficient unless you happen to be, one of Mike Wood's students. Um, so with experience, though, we're all three of us are experienced clinicians. The thing about experience is that you learn what not to do. I mean, experience teaches you because you make lots of mistakes. So you learn what to do in certain situations, but I think more importantly, you learn what not to do. And that's the thing that's been most helpful. I mean, I took a ton of Con Ed out of the door when I was a new grad. I took all of Paris's courses, all of Mackenzie's courses within 2 years. I took all IPA's courses the third year. I took all of Rockabato's courses the fourth year. And I was just like inundated with Con Ed, and I had to kind of figure out how to put that together myself. And the only thing that really taught me that was making mistakes and experience. But it's funny, going back to the original question about like shoulder patterns and it went to knee. I like looking at runners' shoulders, and I think people just, the shoulders don't hurt, but the shoulders are great drivers. And the recent triathlete case that I just treated, his knee, I mean, we all looked at his video. It was pretty odd. I mean, how much crossover he had. Everyone assumed he had right-sided pain, but he really didn't. It was more left-sided. He was definitely overstriding on that side, but most of it, he was coming to me because of his right upper quarter pain. So after I restored his ability to have the MRE as a pattern, according to the SFMA, and he had good overhead movement, and I worked on his stability with some kettlebell carries and some kettlebell rotations for some scapular stability. He just had one PR and a half marathon, and then he won in his age group. I didn't even work on his knee. I haven't even seen him since then. I really wanted to cut down on his overstride. I wanted to work on his symmetrical striking. He was heel striking too much. I mean, this guy thinks he's a mid-foot runner. He runs in zero drops or he runs in Vibrams. And he had a major heel strike, but I think just by fixing the driver and making his shoulders more symmetrical, he had a PR and a trophy. He came in first place in his age group. I didn't even touch his knee or work. I didn't coach him yet. But I think, in terms of single leg stance and frontal plane stability, I think running recreationally, it's one of the only sports that you just decide to go out and do it without any kind of coaching or lessons. And I think that's probably why runners have such a high incidence of injury, just because it's also so repetitive. But they just say like, hey, I'm just going to go buy some shoes and run, and you don't do that with almost any other sport that you really want to be serious at.
I want to shift topics. So go ahead, Mike.
I was going to say, so I guess if my way of summarizing what the three of us just said then is that, we talked about a system, but it sounds like in school we're inundated with just trying to figure everything out, try to figure out how to go through an assessment, and then figure out how to assess joints, right? So maybe that's our recommendation together as the three of us, is we're recommending that you develop a system to assess the whole body and not just single joints. Maybe that's kind of what I think maybe the three of us all said, and maybe we could summarize our advice for the students is, find a system out there that gives you the ability to kind of look at how the body interacts and how things relate to one another and not be so myopic in our approach.
Right. I do have something to add to that too. I mean, everyone always asks, what course should I take? What course should I take? I mean, you can take the best courses in the world, but also what you need is a mentor. That's why I think doing residencies out of the gate is a really good idea. But you don't have to do a paid residency. You don't have to pay for a lot of Con Ed, because if you work with someone who's a very good clinician and has great, clinical decision and advanced clinical reasoning, you will learn more than any Con Ed course. And I think it's more important to find a mentor than any particular course, really. Because you see how to synthesize what you learned at seminars.
And I think we do a lot by just mirroring people and replicating a lot of their actions or their verbiage. And I think the more people you hang out with, and even people outside of our field. I mean, I'll go hang out with pro skateboarders, strength coaches, dancers, and you'll start seeing they're describing a lot of the same things through a different language, but they're looking through they're looking through the same window, but just from a slightly different standpoint. So, I think don't just hang out with physical therapists. Get out there and work with people in other disciplines, because it's only going to help you better understand our field. So.
Right. I mean, in the sports world, big difference between sports and the ortho world. Sports is way more collaborative. You go to an FMS or an SFMA course or even a rock tape course, there's all kinds of people there. But you go to like a traditional kind of like Stanley Paris or Maitland course, it's just all PTs and ortho, and it's very guru-based, and it's kind of like, I don't need an ATC, or I don't need a massage therapist, or I don't need any other clinician. And like the traditional ortho therapist, that doesn't do it all, but really, no guru is an island, no man and their clinician is an island, and everyone needs help and collaboration.
That's a good point.
So just to shift gears for a second, one of the things that I spend a lot of time with clinicians who ask if they can come and hang out with me. I don't know what they're thinking. It's like they lost a bet or something. But posterior shoulder tightness. If you had sort of 3 takeaways for people, Mike, what would you tell clinicians when it comes to assessing the posterior shoulder in an overhead athlete, as well as just general population?
Why are we assessing just the posterior shoulder?
Okay, great. There you go.
so all right. Let me make sure I understand that right. So what are my 3? Rephrase that for me. Sorry, I'm slow tonight.
Three clinical pearls when it comes on the topic of posterior shoulder tightness.
Okay. All right. So I guess first thing you have to understand is this goes for any joint that's rotational in nature. So your hip, even like your cervical spine or whatever, you can't take one direction of a rotation in isolation. So, even not to shift gears, but use it as an example because we always talk about the shoulder, but let's talk about cervical rotation. Let's even use an SFMA-based cervical rotation. And what if I pass both of my cervical rotations on the SFMA, but one of them they both pass, but they're asymmetrical? So, Erson, what would you grade that on SFMA? They both pass the criteria, but it's asymmetrical, meaning one goes less than the other one.
Well, it's not. One of them's not a pass then.
No, they both passed.
Well, I would say one of them's not a pass because I'm looking for symmetry, and within reason, I'm looking for symmetry because obviously someone may have some sort of congenital deformity or something like that. But the average person, technically, according to that system, it's supposed to look and quality and quantity, I think, are part of a pass. And I think one of the things is people say like, oh yeah, chin to chest, that's a pass. But if you're holding your breath, or you're struggling to get it, I mean, there's a dude in my course that I just assisted Charlie with. He's like, yeah, I'm getting my chin to my chest, but he's really doing it's like a high threshold strategy. So if it looks symmetrical, but one is a struggle, and you can see them like using a more high threshold strategy versus one looks very, very easy. The one that is easier is the pass.
All right, so I see what you're saying, but that's not what the system says. So the system says, can you rotate, and actually we got rid of the chin tuck, by the way, so it's just rotation now, and can you get it to your mid-clavicle? But anyway, whatever. Yeah.
Oh.
But anyway.
New breakouts. It send us into breakouts.
So it's a pass or a fail, right? So either it's a dysfunctional or functional. So you get to a certain point, and I pass. Now let's say I get to this side, I pass, but I go 10 degrees more. They both passed.
Right, because they're getting to the points. Yeah, I mean, I still consider it an asymmetry. I consider it, unless it's like instability, within reason. Say someone's doing an MRE is a better example, and one side reaches the inferior angle of the scapula, but the other side easily goes, almost looks like they're doing like a reverse high five behind them. I still consider that an asymmetry. I mean, because you're still looking for asymmetry, and not just the minimum. Like they're saying like, hey, this is the minimum that you should get, but I still look at that as an asymmetry.
All right, I'm gonna go back to the neck. Let's look at one. Okay, do I pass?
Do you pass? I don't know. Did you? Let me see. Do that again.
What do you grade me?
Let me see.
Trust me, I pass. All right, just go with it.
I
But
don't
I
know.
pass.
That looks like you didn't quite touch.
You went to the right. I
Yeah.
passed.
Yeah.
Right.
Yeah.
We move on. Now I go to the left. I pass, but I'm 10 degrees more. Okay, so all I'm getting at here, so it's asymmetrical, right? Which one's the fault?
Well, I don't know. I mean, again, there's still an
I'm going to circle
asymmetry.
back to your question, Chris.
One side is unstable. If one side is unstable, I don't know. It looked like to the right that you actually had a little.
Let's just pretend I had fault. Erson?
I don't know. I mean, this is just like I feel like this is kind of cut and dry for me because I was really taught it's true or false, and it's not like you can have a bilateral pass and an asymmetry. Because I think I'm looking for asymmetry, and this is the way I interpret it. I mean, certainly I'm not an SFMA instructor, and also, I trust my buddy Charlie Weingroff, and he's one of the ones who's like high threshold strategy, low threshold strategy. If you're really trying, like if you could easily get, let's just say you pass, you think it's a pass but you have extra motion. To get that extra motion on the right, you would have to use a higher threshold strategy. Like you would have to really kind of crank.
Nope. I didn't.
Yeah. Or let's just say
I don't
that.
have to.
Remember, that's also only active. Passively, would that patient be equal then? Because if passively, then they're equal. Because if I see any kind of asymmetry, I'm still going to check them actively and passively. And if passively, they're equal. And all of a sudden, they have equal amount of motion. That's some sort of motor control stability issue.
So the SFMA has very specific criteria on what passes.
They do.
If you get this, you pass.
Right, but I still look at the strategy. Like I don't think if someone's holding their breath when they're doing an MSR, as long as their shoulders are level and you see the front, and
I agree. I'm not holding my breath.
Right, right.
I agree. I'm just talking about somebody that rotates. Let's just say rotation.
Yes,
Okay, it's simple. I pass, but they're asymmetrical.
yeah. I mean, I would just say, look, I use a little common sense too. If you're getting a 90 on one side and 110 or a 95, 97 on the other side, I'd say that's all right, especially if there's not necessarily a complaint up there and your shoulder patterns are good and your thoracic patterns are good.
So here's a question. Let's make it up, the numbers, because I don't know. There's no specific number, but let's say it's 90. Okay, that's pass, and I get 90, and I get 100 to the left. What do you do? I'm asymmetrical. You try to get my 90 100, or you try to get my 100 to 90.
Well, I mean, there's a lot of different ways to look at this stuff too. Because if you're looking at some kind of like PRI thing, it's like they believe there's only a fixed amount of motion you can have both ways. So the hypermobile motion kind of like needs to be taken down. I'm more of the school of thought. It's like, well, that's such an extreme example because you're already like pretty good. I mean, that's like saying if like someone has 10 degrees knee hyperextension, someone has like 15, 20 degrees knee hyperextension, and I'm pretty good with like the 10 degrees. And I'm not going to try to tone down the other one because if it's lax, sometimes the muscles can only control it so much. If it's not, are you symptomatic? Is this hypothetical patient symptomatic? Because if it's not really bothering them, and my thing is like I actually also look at like retraction and low because I'm a McKenzie guy. If that's limited, maybe I'll work on that. But otherwise, if someone is getting to normal and beyond normal, I'm probably not going to try to stabilize the hypermobile one unless it's an issue. I mean, if you're looking over your shoulder and you're passing out because you're like stressing your vertebral artery or something, it's probably an issue. But that's a pretty simple thing. Don't look that far.
So I get this highlights a good example. This highlights a very good example. You're non-committal, which is fine, and so you're saying it depends, and you do further testing. I like that. That's what I got from your answer. It depends, and you have further testing. Good. The problem with these systems is they say it's pass-fail. The problem is when they're asymmetrical and they just automatically give you a fail, you don't know if it's the side that's too little or the side that's too much. So circling back to Chris's question from an hour ago, it was it's anything we talk about rotational, so going back to the shoulders, you have to look at both ends of the spectrum together. So you have to look at a total rotational motion no matter what. So in the shoulder, it's ER-IR. With the hip, it's ER-IR, right? In the neck, I think it's a rotation. I do the same thing with the neck. But anything that's a rotational type thing, you have to look at them together. So you can't look at the hips. If your left hip's got 10 degrees IR, but it has a ton of external rotation, then the issue is not your internal rotation. And if you just treat that internal rotation, you're probably going to screw something up because you're not looking at the big picture. So again, to go back to Chris's question, what do you do with the shoulder when we're treating for posterior tightness? The first thing we look at is total rotational motion. And that was a really long rationale as to why we do that. And you can see it's not very clear, right? Because like we even discussed it, it's not clear.
Well,
You know?
That's a great example, though. I mean, I can't think of a better way to illustrate that. And that gets it. You have to really be critical of your goniometric assessment, you know? And again, not to blow it off. I mean, Tim Tyler and Mike Mullaney, Mal McHugh, and I did a manuscript too that shows that, you know, basically 5 to 7 degrees is measurement error. So you got to really be critical with that measurement to the best of your abilities, especially in an overhead athlete. And I guess something that this sort of, you know, brings up another point. I deal with this in swimmers a lot. You know, now you have a bilateral overhead athlete with the preferred breathing side, and it's like, you know, you're opening up a can of worms. So. But I interrupted you there, Mike.
No, that's good. Well, let's talk about your posterior shoulder tightness test, which, you know, so that's a good example, right? So posterior shoulder tightness, you're doing that drop arm test. You know, for the people that aren't aware with it, Google it. But with your posterior shoulder test, you're showing that they're tighter on one side than another. Are you, or are we just starting in a different alignment? That's the question we don't know. Is if your scapular plane and your fossa are in a different orientation, then that completely changes your test. And then if you just stretch because it didn't get it, now you've kept the poor alignment and overstretched to compensate to get your number, just because you wanted your number. Because we're like knuckleheads for assessments, assuming that the sagittal plane and lying on a table, everybody's symmetrical.
Yeah.
So that's the tough part with all of our things. You know, we just measure ER, IR in the shoulder. If you're doing that on a table in that plane, you're just totally disregarding the position of the scapula, and it's predisposed to one.
Right. And again, if we take away again what we're all saying is you just need to really look at more. You know, I even just wrote today, I consider symmetry in either FMS or SFMA as like the minimum that you need. Like it might say that, yeah, you're at less risk for injury, but you may not have the capacity, and it certainly doesn't, you know, it doesn't cast as wide a net as they say it does. But if someone has a clear asymmetry, because I wouldn't call that like this really obvious need to take care of asymmetry in your example, but someone has a clear asymmetry, like a 3-1, or someone's painful on one side and limited, and someone's got clear, easy motion on the other side, that's something you got to clear up first. And it doesn't mean they're going to have the capacity. It doesn't mean they're going to have functional form. They're still going to need some training to go back to whatever it is they're doing. Unless it, you know, the more active it is, the more active they are, the more coaching they'll need. I mean, if someone's job or hobby is just really to walk from their car to their computer at work, and then they walk back to the car, and then they sit in front of the TV all night, they're probably pretty good without any additional training. And once you get rid of their pain, but the more active someone is, and the more they move, they're going to need something other than just pure symmetry. I just look at it as the minimum capacity that someone's needs. Start there.
And for somebody that's just learning some of these movement systems, like you use some of the FMS terminology there with the 3-1, but I think a big take-home for somebody new to the system is, if you have somebody that's a 3 and a 1, your goal is not always to get them to be a 3-3. Your goal might be to get them to be a 2-2.
Right. Athletes and really competitive people, they want like all threes, but you just want symmetry.
Yeah, I don't know if all threes are good sometimes. You never know. I don't know if I like all threes, but
No, I mean, McGill just basically proved that small ectomorphic females can score higher than a 15 or 16, and they may not have the capacity. They're still at risk for injury. So
right.
It's about capacity too. So I start symmetry.
Yeah. So Chris, did we answer your question?
I think it's good. I think that people get pretty aggressive with some of their interventions, and I think that you have to sort of approach with a little bit more caution. I think that's something that, the longer I'm out treating, I start to get basically less aggressive and just, I guess, a little bit more refined, or not cautious. I try and really say, what are the drivers? What's everything that I need to be considering going into this situation? So.
Yeah, that makes sense. You got to have all the facts in front of you. The more we do this, the more you realize that if we're just throwing treatments on top of people without a full assessment, then you're guessing. So I think you said you have to find all the drivers, and that's hard. I mean, I'm sure right now we all think we have a good system to find the drivers that are going to drive our treatment, but I guarantee in 5 years we're going to be adding even more to what we're currently doing.
Right. I'm a fan of being a reductionist in lieu of advanced clinical reasoning, but I still think we all need, once you get so far, I think Harrison Vaughn kind of talked about recent research that showed that, you get so far and you really hit a plateau. And for me, that plateau is like, I get the majority of my patients better in 4 to 6 visits. But I still want to learn more different types of assessments and different treatments because I want to be able to help people who don't fall into that category. I don't think, though, I mean, it's been years since, that visit average has lowered, but it doesn't mean that I'm kind of like resting on my laurels because there's always going to be someone who's not going to respond to something. Maybe I don't have the buy-in. Maybe, my interaction isn't good enough. Maybe I'm not enhancing placebo enough or whatever, but there's always going to be someone's going to need, they're going to respond for whatever reason for something that you don't quite have in your tool bag, or you're going to have an assessment it's missing whatever they have. So, the more experience you get, the better you get at recognizing patterns. That's what makes, that's what research shows. It makes people an expert is pattern recognition. But for me, furthering my learning is just all about helping people. That there's always going to be someone you can't help, and that's why I continue to further my education.
Yeah.
I feel like having a beer now. Are we done?
I know, seriously. Yeah, I'm gonna go ahead.
Mike, what research are you up to these days? Are you working on any projects in particular that you're able to discuss?
Most of my research the last 8 years or so has been mostly baseball related, and I've been unable to publish all of them. We consider most of our research now kind of competitive advantages, I guess.
Yeah.
So, we don't, I haven't been researching. I mean, I leak out the info here and there, like on the website, with just little tidbits and stuff like that. But in terms of like full articles, don't really, have that brewing up as much. I'm just at a different point right now with what I'm trying to do with my research. I'm trying to, so still conducting it, just different, but so I get to use it all the time, but I don't get to share it as much. So it's like I'm hoarding all this info.
I would. Neither of you guys hoard too much info that.
I guess. Yeah, we sneak out more than you think. My next big focus is going to be on the youth. I mean, not that I haven't been, but I'm going to deal a lot with youth, especially with the baseball players. It's obviously a passion for me, but. We're just getting out of hand with the injuries that we're getting with here, and we need to do more just dedicated research there. I've spent the last 15 years of my life researching how to help the pro guys, and I think we're wrong. I think we need to fix it at the kids because it's too late when they're in our hands. I'm just controlling their fall.
Yeah, I agree with that. I mean, typically the pros have better coaching. They have better periodization. I mean, youth that play soccer all year round. I mean, no pro plays soccer all year round. That's one of the biggest problems. I mean, my girls were in gymnastics. We were debating whether or not to pull them from team, even though they're on only level 1 and barely level 1, and one of them's going to level 3. But I think the gymnastics is one of the ones that's actually pretty good because it's a pretty varied sport.
Right.
I think the more varied the sport is, you don't run that risk of overuse injuries. So that's the only thing I mean, when they get injured, it's not going to be the overuse. It's going to be because they're going to fall off a beam or something.
Yeah. Sorry.
Oh, go ahead.
I was just going to say, I just worked with a 12-year-old today that told me how much he pitched the last year, and I looked at him. I said, "You realize you're throwing more than the big leaguers, right?"
Right.
There's a reason why those adults don't throw that much. Why are you?
Right, and maybe it's not even a coach's fault, because maybe obviously that ends. But I mean, then their parents just put them in like another league,
Yeah.
And that's really the problem.
Yeah. What were you going to say, Chris?
No, I was just going to say, it's funny because I think a lot of times people, they like to pigeonhole me, which is just, I think it's natural, into running injury management. And, what landed me in this field was baseball, and I went from baseball to tennis, and I was dealing with a lot of shoulder issues when I was pitching, and then I went to tennis and had an acromiale that they ended up fusing together. And I agree with you guys. I think what's missing is really helping these young athletes to develop good habits. And this is just such a pitfall among a lot of the older individuals or adults that I'm working with is, when they come in, whether it's a runner, whether it's, any, irrespective of their sport, I say, well, let's sort of look at this objectively. How did you land yourself here? And it's always bad habits and bad decision making. And I think if this is something that we can instill in kids from a very young age, that's going to be a big chunk of it. I think that it's great to hear you say that, Mike, because I know that had someone been keeping a little bit closer eye on me as a young pitcher, that I could have probably taken my career a lot further. So, I think a lot of people are starting to say, and I don't know if this has just been over the past few years, but it's prevention, more than anything, because like you said, by the time that we catch, it's sort of crisis management with a lot of folks. The older they get, and I went through five major surgeries, and over the past 5 or 6 years, where I've been pushing my body, more than ever before, I'm much more mindful of rest and basically making good decisions, dialing it back if I feel I'm on the brink of something. And in a sport like triathlon, which people just think, it's a ticking time bomb, which it is to a degree, I haven't had any injuries, So.
You're a machine, though. I think
I make good decisions, and I'm very mindful, and I don't say, oh, I had a stressful day, I'm going to go put in a really hard bike or run. That's when I'm going to dial it back. So.
Yeah. I'm just so jealous of your motor control.
What's that?
I'm just jealous of your motor control.
All right.
It wouldn't be that impressive if you guys knew how much time that I spend marching around Seattle.
I can tell that you do. It is not. It does not look like that totally comes natural. I can tell you spent hours of practice.
Yeah. Well, I think that goes for anything. So.
Yeah.
All right, guys, that was fun. I appreciate it. I gotta run.
Yeah, guys, thanks for hanging out. That's nice. My glasses look
Erson's. Are these yours?
Stretching out my glasses.
Wait a minute, I thought you put on the joke Google effects right there. That was a
real sunglasses thing. Yeah.
Yeah.
All right, guys. For those of you who watch, thanks. But I mean, this was also recorded, so I'll give you the link and you can share it on your social media. Okay.
All right, thanks, guys, and thanks for voting for all of us on Therapedia. It's amazing to see that people come out and support us, and it sort of keeps us hungry and active online.
Thanks, guys. Take care. Good night.
All right, we'll see you.